I'm Dr. Dirk Lee. It's my pleasure to introduce Dr. Amer Samdani, who's the Chief of Surgery at Shriners Hospital for Children, Philadelphia. He's a neurosurgeon. He sits on the executive committee of the Harm Study Group and is a board member of the Pediatric Spine Study Group. He has published over 250 peer-reviewed articles and given over 100 invited lectures and grand rounds presentations. Now, a major focus of his clinical work is on non-fusion scoliosis surgeries, such as vertebral body tethering. We'll get into the latest data and updates in today's interview. Dr. Samdani, thank you for granting me a second interview.
Derek, it's my pleasure to be here.
Now, I think my first interview with you was about 4 years ago, and lots has happened in the VBT space since then. Initially, most of the surgeries for VBT were in the thoracic spine, and that's shifted a little bit more towards lumbar VBTs. Can you give us your current take on VBT, thoracic versus lumbar, and where it's kind of headed?
Yeah, so, what's happened is we've learned a lot about VBT over the last 5 to 10 years. There's a couple of knowns that we know for sure. We know that VBT is going to have a higher reoperation rate than what would be considered the gold standard, which is posterior spinal fusion. But on the flip side is we've also learned that VBT is going to preserve motion more so than you're going to be able to fusion, where there's essentially the complete loss of motion in the areas that are being fused. So if we take both of those elements of information that we have and we do a risk-benefit analysis, we'll recognize, or we've come to recognize, that VBT has the biggest impact in the lumbar spine, where that motion is most relevant, and where degenerative disease later in life becomes most relevant. That being said, we still believe in VBT in the thoracic spine, but it has to be for select patients. And by that, I mean patients that have the right curve type, enough flexibility, and what we've learned over the last couple of years through work that Dan Hornschmeyer and others have done, that they have to be at the right skeletal maturity age, meaning most ideally, if they're a Sanders 3A, thoracic VBT is still a very viable, and for many patients, a better option than thoracic VBT.
With thoracic VBT, I believe, and correct me if I'm wrong, but part of the issue was that initial candidates were being accepted if correction was possible down to about 30 degrees. Are you finding that it has to be even more flexible than that and has to go to maybe 20 degrees to be a viable candidate?
Yeah, I would say the more flexible, the better for sure. I still feel 30 degrees in a patient that has significant growth, meaning a patient that's a Sanders 3A has significant growth, 30 degrees probably works. But I've also recognized that if they're bending to 35 degrees, but they have minimal growth, that they're probably not an ideal candidate.
Understood. Do you feel that the issues with overcorrection, if you go lower than 3A, are still problematic? Because I know some surgeons have been maybe going a little bit lower because they're hoping for more bone growth modulation and correction after surgery.
Yeah, it's again a great point. I would say overcorrection occurs for a couple of reasons. Number one is if you have a more mild curvature that's very flexible in a very young child. So by that, I mean a 40-degree curvature that bends to 10 or 15 degrees in a child that's Sanders 2. Those would be all three risk factors. We've done some research on this, as has Dr. Allen and others. But if you're a Sanders 2, but now you have a curve that may be 60 degrees, that bends to 30 degrees, then you would still be a candidate, because in order to overcorrect, especially throughout the apex, you would need more growth than you're going to have even at a Sanders 2. And then the third aspect, so number one is going to be age, as gauged by Sanders. Number two is going to be curve magnitude, as gauged by the Cobb angle. And number three is typically we've learned a lot. Today, we know that there's certain that there has to be a differential tensioning across the tether, meaning maximally across the apex and less so at the distal ends to avoid overcorrection. Taking all that into account, you can minimize overcorrection, but the bottom line is no one has this crystal ball that can truly determine how much growth you have remaining. And then even if we were able to determine very actively how much growth you have remaining, to be able to correlate with how each element of the spine that's tethered is going to respond to that growth and in what proportion. So there's a couple of missing pieces, but I can tell you that overcorrection today is less common, at least in our practice, than it was previously, because we've improved our indications and we've improved our technique.
Now let's talk about tether ruptures in the thoracic spine. Of course, it was a new surgery 10 years ago, and you're dialed in your parameters much tighter. You've seen the tether rupture rates falling as a result. Can you give us an update on what you're seeing now?
Yeah, so tether ruptures are going to occur if the spine doesn't modulate enough over time, meaning where there's truly a change in the vertebral bodies through growth modulation. And eventually, being a mechanical device that has motion in it, it's going to rupture. In our studies, we find typically those ruptures, at least with the tether system, and we're using occurs at about the 3-year mark. What we found is in the lumbar spine, we've been double tethering and doing 2 tethers. And without a doubt, that's going to decrease our rupture rates, but they're still going to occur because, again, it's a mobile spine. But what we found is that if you double tether, even after it ruptures, there's less loss of correction and the time to rupture takes longer. In the thoracic spine, you can definitely put 2 tethers in as well. But because the vertebral bodies are smaller in the thoracic spine, it can be very difficult in some of the areas because there just isn't enough real estate to get 2 tethers in. And then you have to do a risk-benefit analysis because of the thoracic spine. You don't want to induce any iatrogenic harm by being near some major organs. So that ends up being our thought process when we think of tether ruptures and how we can avoid them. So ideally, patients that have enough growth remaining. Number 2, trying to double the tether whenever it's feasible.
Do you have some actual numbers in terms of current rupture rates for both thoracic and lumbar?
Yeah, so our most recent data set, which is consistent with what others have published, including Dr. Tillich in Germany and Dr. Launer in New York, our lumbar tether ruptures are going to occur anywhere between 50 to 60% of patients, with the understanding that the vast majority of them are not going to require reoperation. They're going to be a radiographic finding where you may see an increase in the curvature of up to 3 to 5 degrees. In the thoracic spine, the numbers, again, are going to vary depending on which series we're looking at, which set of patients. Somewhere between 20 to 30% of the patients will have tether ruptures. But again, very similarly, the vast majority of those will be clinically insignificant. The data that we're really trying to hone in on is what that rate's going to be when you have double tethers. I know for a fact it's going to be lower, but we're going to have to really get that data out and study it to make sure we understand how much lower. Some people have stated that it's going to be about 13%. So those numbers are going to be significantly lower than what we've seen for single tethers.
Okay. So we'll double tether a lot of the thoracic as a result?
Great question. So typically till about T8 or so, we'll try to do a double tether. T9, it just depends on how big the vertebral bodies are. In the lumbar spine, pretty much every lumbar spine gets some component of a double tether. Again, because the rupture rates are higher, the vertebral bodies anatomically are a lot more accommodating for 2 screws. And secondly, what we found is that double tethers, at least in our preliminary analysis, are going to decrease rupture rates. In the thoracic spine, it's just more challenging because the vertebral bodies are small.
And they're a bit softer as well.
They're a bit softer, exactly.
As far as you know, and you would know, is there any new technology coming out? Are there any companies who are also trying to look at different materials? I know it's difficult because it takes so long to have them cleared with the FDA.
Exactly right. Exactly right. And so I can tell you the vast majority of companies that are in this space are looking to come up with a newer and better tether. And that would be remarkable. If we can increase the longevity of the tether, it's going to make this operation more common without a doubt. With respect to the current tethers that are on the market, I think it's really difficult to ascertain if one is better than the other because there's so many different factors. I don't feel that it's just the thickness of the tether that's going to determine breakage rates, at least the literature that I've seen, because I've seen literature that implies that even with that thicker tether, that it may still be very high. I think it's a combination of tether material, but also how the instruments interface with the tether, the set screws and the other instruments. So definitely, I think it's still undetermined if there's really a better tether. One tether is better than the other.
If just to rewind a little bit, what are the best curve types for thoracic VBT?
For thoracic VBT, the best type of curve types, and we've learned this over the years, are going to be what we call linking one curves, meaning these are curves that have a main thoracic curvature. Typically, we have to be, with tethering, because it's not as powerful as having rods in it, they should not have too much lordosis, although we've had patients that have had lordosis that we've operated on who've done fine, but it is something for us to keep in mind. We should stay away from curves that are linky to curve types, meaning curves where there's a curvature at the top of the spine, proximal thoracic curvature. Because what that does, Derek, is you can only treat the curvature up to approximately T5, maybe T4, and that can really offset a child's shoulder. So I would say with respect to thoracic spines, it'd be the linky one curve type. That's the ideal tether.
I believe at the beginning of the VBT process, there was more hope for bone growth modulation post-surgery, right? Can you talk a little bit about what you anticipated at the beginning and what you're seeing now?
Yeah, so that's a great question. It's something that's generated a lot of debate and interest. And there was a recent paper earlier this year that was published in one of our big journals. And I believe the title was something to the effect that, growth modulation doesn't occur with VBT. And I know the authors of that paper and I've spoken to them. And if you look at the data, actually, I think it actually shows that the vast majority of patients are actually under 30 degrees at their most recent follow-up, which I believe is 4 to 5 years out. So the majority of those patients have actually done well. The question is, and the crux of the question is, let's say you have a 50-degree curvature, and now you bring that curvature down to 25 degrees, at the 6-week follow-up. And 5 years later, that curvature is still at 25 degrees. Have they growth modulated? I can tell you in my experience, I would say that there's some changes that have occurred, even though the curve may not have changed, because the tether would have broken and there would be a recurrence of the curvature for those patients. But others feel that if there's no change in the magnitude of the curvature between that first direct or 6-week X-ray and the most recent, that they haven't growth modulated. But the reason why at 5 years, if their curve hasn't changed, they must have had some changes within the vertebral bodies. Otherwise, they would have had worsening of the curvature. So I think we're still really trying to define what the term growth modulation with respect to vertebral body tethering means. It's easy when you go from 50 degrees to 30 degrees to 15 degrees. We recognize that. That's easy. It's also easy if you go from 50 degrees to 20 degrees back up to 40 degrees, meaning in that case, you probably didn't modulate. And in the first case you did. The real question is, many patients go from 50 to 25, and then they stay at 25, 26, 27, or 22 degrees. And where does that patient fall? I would say, in my mind, that's a success. That's a patient that's avoided a fusion and has likely shown some element of modulation, where others would say, no, there has not been any growth modulation. And we don't know who's right or wrong. It's just two ways of looking at it.
Okay. Good question. Great answer, I should say. You're at Shriners Philly, they were looking at bracing for some types of VBT in terms of patients. Has that become more common post-surgery?
It is, again, a great point and something I don't have data for, but I'll tell you anecdotally. If there's a large curvature, because, we at Shriners are trying to push the limits of VBT in as responsible a manner as we can. By that, I mean, we push the limits a bit and see how patients do, obviously doing appropriate consent, so shared medical decision-making for all these patients. But then we want to see how patients are doing and we try to study them. And I can tell you, bracing can occur in VBT patients post-surgery in a couple of different circumstances. Number one, let's say you have two curvatures. You have a thoracic and a lumbar, and you just tether one of the curves. Sometimes we'll brace the other curve because the child still has growth remaining and we want to do something for the other curvature as well. And I'd say that generally works quite well. The other scenario, which is less common, is if you have a larger curvature that may have only bent Derek, to 35 or 38 degrees, that through a shared medical decision, we thought VBT was the best option. For that patient, what we'll do is we know that when they stand up, the curve is going to be 38 or 40 degrees, but we also feel the patient still has growth remaining. So what we'll do is we'll try to get additional correction through bracing. And I want to be honest with you, I've been quite happy with that process. It hasn't worked in everybody, but I've been happy. But I don't have quantifiable data where I could say that I would recommend it for our routine patient.
Yeah, makes sense. You kind of stick with a traditional TLSO brace or more of a nighttime brace for those particular patients?
Yeah, so we do stick in our hospital right now. We're still utilizing the Boston TLSO brace. We usually start with that because if we needed to increase the bracing time, then we can do that. We can start at night, but let's say we decided or the child decided they want to wear it after school. It's easy to do with that brace. Whereas a nighttime only, meaning like a Providence or a Charleston brace, you wouldn't be able to carry that on during the day.
With respect to the lumbar spine, what are the parameters that you're looking at right now? Because I believe that you are also accepting patient parameters a little bit more higher up in the Sanders scale because of the lumbar spine taking a little longer to mature, et cetera. Can you talk about that?
100%, Derek. I can tell you, we are learning so much about VBT and the lumbar spine. So whereas in the thoracic spine, I feel we've got a good handle that you need a Sanders 3A. In the lumbar spine, you're absolutely right. And I've even done Sanders 7 patients. And to my amazement, those patients, when we do a double tether, you have a flexible curve that maybe 50 that bends down to 20 degrees. Those patients can actually even overcorrect a little bit, and not in a bad way, meaning not that it's causing them any bodily changes, but in a manner that really shows me that even at that Sanders stage, they're actually growth modulating. Because the only way you're going to actually overcorrect is if you growth modulate. So we are learning a lot about this, and I feel that for that patient population to try to avoid a lumbar fusion, in my opinion, may be worth, again, for the right patient to take that chance, because you can always do a fusion if you needed to. I have had a couple of patients that were more mature that eventually did break the tether. One I can think of, she had probably a 55-degree curvature. It was down to probably 15 degrees. She's 5 or 6 years out now and broke, and she's probably at about 20 degrees, but she's not going to need the fusion at this point. So in some aspects, if the goal was to avoid a lumbar fusion, we were able to achieve that goal. Now, do I think that we should be operating on patients that are 40, 50, 60 years old? I am not in that mindset just yet. I think that we would need improvements in tether materials and technology. And to me, that is a little bit further off to the side. I think I really want to understand how the 15-year-old or 16-year-old, that's a senior 6 or 7 responds before we can, start just gradually pushing the limits.
Well, do you feel that the lumbar spine does continue to growth modulate after Sanders 7? And you have an idea of how much longer after Sanders 7 that it does modulate? That's the thing, eh?
No, it's a great point. And whether we use the term modulation or correction, from the Cedar-Volkmann principle, where compression will inhibit growth on the convexity, I do think that occurs even in patients that are adults. How much it occurs and at what age it stops, I'm not sure. And how much is going to be enough to get an adequate result? We're still figuring that out, but for sure, in a 14, 15, 16-year-old child who may have growth plates that are nearly closed, I feel in the lumbar spine where the vertebral bodies are larger, I have seen some really good results for sure.
Do you think with more movements in those lumbar vertebrae compared with thoracic vertebra, that plays a factor in extending growth modulation in that particular area?
Yeah, that's a really good point, Derek. And I have not thought of it that way, meaning the more motion may induce more growth, but it could be a possibility. I just haven't thought about it in those terms. I've always just thought about the size of the vertebrae, and given that they're a larger size, that even if they're proportion going to grow another 10%. It's going to be more so than it would be in a smaller thoracic vertebrae.
Okay. Interesting. I do want to touch on a complication with lumbar tethers.
Yes.
Going to L4, for instance, and having to do a trans-psoas approach to get those screws in. Are you still seeing complications, for instance, with the sympathetic nervous system, hot, cold feet, that type of thing, or nerve symptoms down the leg? Are you able now to moderate those effects?
Right. The lumbar tether, perhaps higher reward, but certainly some higher risk for sure. The sympathetics, that's really difficult to control because, you can't visualize a sympathetic chain very routinely. And when you're dealing with dissection, it'll often get taken. Most of the time, I do notice that patients show some degree of improvement in the hot, cold, and symptoms. Typically, you take the sympathetic chain on the same side or the ipsilateral side, you lose your ability to vasoconstrict, you get vasodilation, and the feeling that the foot is warmer. Almost always we'll see it to some extent immediately post-operatively, with some improvement over time. With respect to the lumbosacral plexus, I can tell you that we did try trans-psoas approach probably 10 years ago. And I did have a couple of patients that had some permanent nerve loss, not motor, but sensory loss. Since then, we now peel the psoas back, and the incidence of that occurring has gone way down. But one thing is for sure, and I tell all of our trainees and our surgeons, you want to use the smallest tulip screw that a system has. So again, you want to pick a system that has the smallest profile screw, because I have seen systems where the screw profile may be higher. I think because then what happens is you have a higher tulip coming from the bottom onto the psoas, and it can pinch the nerve from down below. So I would strongly suggest, using the smallest profile tulip, and one of the systems is actually smaller than the other. And that's been my main reason for utilizing one of the systems, is because in the thoracic spine probably doesn't matter. The tulip, not as the size, height may not be as important, but in the lumbar spine for sure, in my clinical experience, it does matter for sure, because what you said, you've got the psoas coming, you have the lumbosacral plexus that runs on the bottom of the psoas. So you could have a tulip underneath that can pinch it. And I've seen referrals where larger tulips have come in where you have seen some missing for sure.
Fascinating. My next question is, perhaps we can jump to VBT hybrids now, specifically selective thoracic fusion with lumbar tethers. What type of patients do you choose for that? Double curves, I suppose. Perhaps you can talk about the parameters for that.
Derek, we've been leading the charge on this. We've published one of our, one of the earliest papers, I should think the earliest paper on hybrid. We have another one that we're getting out right now. I absolutely love this operation. And the reason is, number one, you start with a patient that's been told, or looking at their curve types, they would get a fusion lower into their lumbar spine. So that's the starting point. And these are larger curves. So now for tether alone, ideal curves are probably 50 degrees, 45 to 55. Here our average curves are in the 70s. So these are kids that have really large curves that 100% would have gotten fusion done up and down the spine. And what we found is even kids that are a little more mature, if you fuse the thoracic spine by itself, it's going to cause some correction in the lumbar spine. And then if you add the tether, I have not had to do a fusion on one of these kids yet into the lumbar spine where it failed. Now, it doesn't mean it's not going to happen. It certainly can happen. You need more follow-up, but I am extremely excited. And fascinatingly, these curves are, again, average was, I believe, 68 degrees in the lumbar. These are large, different curves. But in the lumbar spine, you can still see some overcorrection. So I've had to go back and do little snips of the tether, 2 levels. It's taken half an hour, 45 minutes for overcorrection. But I don't think any of those kids are going to need a fusion. So I tell our patients right off the outset, we're going to do our best to avoid a lumbar fusion, but there's a chance that you may need a second surgery for overcorrection. But I am thrilled. We get spectacular, much more reliable results. And it's probably one of my favorite operations.
When you do that particular procedure, is it all done in one day? Because I know some centers do it separately as well, right?
Yeah, absolutely. There's certainly a subset of patients where it can be done in a single day for sure. sometimes when there's really big curvatures, like an 80-degree thoracic curvature, there can be a lot of surgery for a patient in a single day. So then, because you want to make sure that when you're not shortchanging ICO, that you give your full attention, you take as much time as you need to get maximal correction of those thoracic curvatures when you fuse them, because we typically will do the fusion first. And then in those patients, we'll end up splitting them up to 2 days. But we've done it both ways. I think the most important thing is you want to make sure you maximize correction. And if that means that it needs to be spread out over a day or two, long term, I think it would be, you want to make sure you get a maximum correction.
I suppose that also if you do the thoracic fusion first, you can see how it settles into the patient for the next couple of days, right?
Great point.
Yeah.
Good point. Yeah, you're absolutely right. And you can see how it settles in. And there have been times where I can bend tether even shorter because I saw how it was settling into the spine. And the best curves are curves that would have gotten a fusion into the lumbar spine. There's some double curves where you can just do a selective thoracic fusion. Only a subset of those patients, I think, are ideal candidates. But patients that are starting point is a fusion into the lumbar spine, that's an ideal hybrid patient.
Okay. If the primary curve is thoracic and the secondary curve is lumbar, but the lumbar is under 40 degrees, you probably stick to selective thoracic fusion.
Exactly right. You're exactly right. Exactly right. Just stick to the selective thoracic, see how the lumbar does. And most of the times you will not need to touch it. Once in a while, you may need to do something.
With those patients, I guess Sanders can be a little bit later, like you mentioned. Is there a parameter that you like with the hybrid selective thoracic with the lumbar tethers?
I want to be honest, I mean, I've really pushed the limits on this for sure. I think my patients, I probably have several patients that are 16, 17, even 18 years of age, because I think thoracic fusion helps protect the lumbar tether for sure. Ideally, you probably want some degree of growth. I'd say Sanders 4 or 5. A little bit more mature is probably better to minimize the chances that you're going to overcorrect on the lumbar spine.
Would you consider doing that particular technique with more mature spines versus just a lumbar tether on its own?
Yes, because the thoracic fusion there will definitely help as a protection for the lumbar tether.
Yes, it's pretty interesting. How many patients have you done, or how many cases have you done with selective thoracic fusion?
So our first patient that came out a couple of years ago was about 20 patients that had enough follow-up. We are up to probably, and I don't know the exact number, but between 70 to 80 patients that we've done hybrids on. I myself have probably done about 50 or so. Then my partner Steve Wang's probably done 35, something like that, 30. Okay. And then Phase has done a few as well. So it's getting up there, the numbers, but it is one of my favorite operations.
Okay, it's good to hear that you're having so much success with that. That's great. If we go across the pond to Europe,
yes,
specifically with Dr. Trobisch in Germany, for the last couple of years, he's been doing hybrid VBT with apical fusion, primarily thoracolumbar curves. Have you thought about that procedure and if it's applicable to your caseload in the US?
Again, I like that concept a lot. To me, that concept makes sense. And it's, again, the evolution of minimizing fusion. That's where we need to get to. Is how can we minimize having screws and rods up and down a child's back that's going to limit motion that may lead to degenerative disease in the future. We've actually done a few. In fact, my partner and myself, Dr. Lang, were just talking a little bit earlier. We'll probably put our series out. I think Dr. Trobisch is definitely on the right track, like the procedure and the concept. We're just in our minds just trying to find the right patients that we can start bringing this into our practice.
Yes, I do find that most surgeons prefer the biomechanics of that particular procedure with the apical fusion versus just the tethers to be on their own, especially for more mature spines, right?
Exactly right. More mature, and then again, stiffer curves. But it's interesting, there are many of the lumbar curves, and I've done some big tether only with the hybrid fusion in the thoracic spine. They tend to respond quite well. But I do think biomechanically, just like you're saying, in a more mature patient, an isolated curve treatment, the apical fusion concept makes a lot of sense.
I think Dr. Trobisch has limited his apical fusion to more of the thoracolumbar junction. Would you consider going further down into lumbar spine if you needed to, or would you kind of stick with that same area?
I believe that sticking to the thoracic lumbar junction makes the most sense. As we go further down, then the potential benefits with respect to mobility will get decreased. So I think ideally, let's say you had a T10 to L4 tether you're going to do, then doing a fusion across T12, L1, maybe L1 or L2 to really correct that apex, and then tethering above and below. To me, that makes good sense with respect to the curve correction that we're going to attain, and also being able to maintain the good amount of mobility.
Last question, second last question, sorry. Now, you touched on the fact that you're happy with the hybrid, with the selective thoracic fusion and the lumbar tethers. And with the thoracic fusion, kind of auto-correcting the lumbar spine to a certain amount, then the tethers finishing it off, polishing it off. Do you feel that if you somehow can hold that lumbar spine into maybe, 20 degrees in terms of overall correction, that can definitely extend the health of tethers, keeping that area from breaking in the future?
Yes, you're absolutely right. I feel if you need certain amount of correction, if you have a larger spinal curvature that's residual, then you're going to be more likely to break just because there's more stress. And you're spot on. The straighter you can make it in a mature patient, the straighter it is, the less strain that's going to be placed on it. And when you break, the less it's going to worsen. So your point of if you can get it into the 20-degree range, 25-degree range, 15 degrees, somewhere 15 to 25 degrees, it's very unlikely with what I've seen with our tethers, and as you know, we've been doing them since 2011 now, that curve is going to cause issues later, is my best understanding. Don't have the data for it, but that's just my best understanding of the situation for sure.
The question I had is from the Netherlands with the spring distraction system. I know Dr. Kroot invented it as a replacement for EOS and gross rods, that type of thing, where they'll tension one side and they'll put a spring on the other. What do you think about that theory in terms of the mechanics of it and the opportunity to use that kind of technology?
I love the concept. I know that they're working towards doing some procedures in the United States now. I believe that the ideal patient for that particular device is going to be an early onset patient with a curvature that's larger, because the posterior approach for anything, whether it's fusion or non-fusion, is, in my opinion, superior whenever you can do it to an anterior approach, because then you don't have to deal with the potential anterior complications that we can see. However, what we found over time is any device that we put posteriorly, whether it was the vector or a growing rod or the ApiFix device, although the literature still needs to come out on that. But generally, you take a child and you put a device on them posteriorly, the device autofuses over time. So in an early onset patient, I think it's fabulous because the goal there is to decrease the number of surgeries, understanding that eventually you're going to have a fusion. But in a child where you're trying to avoid a fusion, then in my opinion, if that's truly the goal, then an anterior approach is probably superior, at least in the lumbar spine, where that motion makes a lot of sense, because we've seen a lot of different issues with tethering, whether it's psoas, muscle irritation, whether it's pleural fusion, I mean, there's things that pop up as you do enough of these. But the one thing I have not seen is autofusion. And it's interesting because I was looking for it very vividly and avidly because we had a previous device for growth modulation called vertebral body staples. And with that device, which was really utilized in about 2004, 2005, I did see the spine autofusing, where on X-ray there, you could see bony bridges of bone forming. And at least in my practice, I had not seen that with tethering.
Why do you think that there's a difference between the stapling and the VBT? Because there's more flexibility with the cord?
Exactly. I think there's more flexibility. You're not actually spanning the disc itself. But I just want to qualify that, though. Obviously, the other procedure that sometimes falls into the realm of vertebral body tethering is anterior scoliosis correction, where the discs are released. anytime you touch the disc, I do think then you may set yourself up for fusion. So I just want to make sure I make that distinction, because that I have seen in my practice, not in every patient, in select patients that have been referred to us, but with VBT, where the discs are not touched, we've seen a lot of other things, but autofusion I have not seen.
For those patients who've had the disc releases, I've had surgeons who've also been referred those patients for just a second opinion. And they've had chronic pain typically in those areas because of instability and autofusion combined. Have you noticed that as well?
Yeah, and again, I always want to keep an open mind, because the patients that I'm going to see are the ones that are having an issue. They don't know about the ones that aren't having an issue. But to answer your question, I have absolutely seen that. I'd say the things that I've seen are fusion across the areas that were released, pain across those areas, and actually hyperkyphosis, meaning the patients get too kyphotic in their spines. And those are patients that have disc releases up and down the spine. I mean, these are patients that I've seen that will get disc releases from T4 to T12, and then from T12 down to into the lumbar spine. So that's where I've seen it. When I've seen it focally, because I've had a couple of patients, several patients, I have not seen that to be an issue, at least to date. But I've definitely seen it when there's many, many patients that are treated in that manner.
So with multi-level disc release then. Okay. Just go back to the spring distraction system. Have you ever considered tethering on one side and some kind of distraction on the other side? Just throwing that out there.
I think, again, it's a great question. We've thought about it, but haven't really put it into action just yet. But that would be a great way for those early onset patients. I think that's what you're probably getting at, to treat them in that manner, because a patient that's 6 years old that has a 70-degree curvature, that can be a challenge. We don't really have a great way to treat that patient just yet. So we are been thinking about some of these other options. We just need the right materials and tools. We would need, the right screw sizes and the right tethers to be able to accomplish that.
So besides what we've covered today, is Shriners Philadelphia working on any other top secret projects that we should be knowing about?
I would say the main things are, we are gradually increasing our indications for vertebral body tethering. So we've done several kids that are now 9 years old that would have gotten magnetic rods and had fusions, where we basically did a couple of levels of disc releases right across the apex and then tethered above and below. It's very similar to almost like doing a little apical fusion versus a release, just at a couple levels. And we had some really good results with those kids if you're able to dial growth. And not every single patient, but we have several patients who actually recently published a paper on this. So that's one area. The other area, Derek, that we've been working on is, typically we think of a hybrid as having a thoracic and a lumbar curve, but there's a subset of patients that have what we call an overhang curve, meaning a curve that stretches from T3 down to L3. And could you just fuse on the thoracic spine to T12 and then do a tether below it? So that's the other area that we're really involved in. And then lastly, we're very interested in getting more into the robotic space. Those are really the main areas that we're focusing on.
Excellent. Dr. Samdani, thank you so much for your time and your update on the VBT space. Really appreciate it. And it's really great to hear that the Shriners is, again, just leading this space. It's pretty amazing. Thanks again.
Derek, thank you so much. Thank you for everything that you're doing.